So thank you all for being here. I'm certainly seeing a lot of familiar faces here, and there's some new faces here, and thank you everybody for making the time to listen to these updates that we have from what is, I think, not even arguably the best and most comprehensive breast cancer conference of the year that we have in San Antonio every December. Now, I'm going to spend time talking about some highlights from the conference that I consider to be under the purview of surgery. And my colleagues, Dr. Myers from Medical Oncology and Dr. Gerber from Radiation Oncology, are also going to give some highlights. You can expect that there is going to be a little bit of overlap. We probably have certain things that we all think are very important, but hopefully there'll be enough of this that's distinct that you'll get a flavor of the overview of all of these different topics, and then we'll have some time for questions at the end. I know that everybody's going to remember that if you're going to ask a question, it's got to be a general question. It can't be a question about somebody's specific health-related issues, okay? And we'll remind you about that when we continue. So I also like to split my talk up into different basic topics. And one of the topics that is really interesting and important to me is genetic predisposition. And there was a terrific talk that was given at San Antonio by Dr. Fergus Couch, who is one of the international luminaries in this field and gives a great talk every year about something different at San Antonio. So what he took on this year was the topic of variants in genetic testing. So we do a great deal of genetic testing now looking for predisposition genes for breast cancer. And when we find a deleterious mutation, it means that there's a change in DNA in a gene that results in someone being at increased risk to develop cancer. But people are all very different from each other, and there's a lot of variability in people's DNA. Some of it has nothing to do with producing diseases. Sometimes it's very clear that people just have differences in DNA. That's called benign polymorphisms. It means it's just a difference between people. But increasingly, as we do more and more genetic testing, we also find variants that we cannot classify, that we don't know if they're important or they're not important, and they're called variants of uncertain significance. And there are a lot of them out there. And Dr. Couch and his group said, you know, it's hard to figure out when these variants come up whether or not they're important. Sometimes what we do is we just wait for years and years and collect a lot of information and then figure it out by following people and seeing if it translates into an increased risk for breast cancer. Dr. Couch said, can we find a faster way to do this? So what they did in this analysis is to look at databases that include these variants in BRCA1 and 2, and they looked at more than 3,000 individual variants in these two genes. And what they did was to say it's really important for us to look at these variants because we don't want genetic testing to give information to people that's unclear. We want to be able to give them information that is giving them a better sense of their risk for breast cancer, that impacts on how they do screening for breast cancer, that impacts on who would be recommended to do interventions like surgery or change cancer treatment options. And we want to give people clear information that doesn't just make them anxious, so it is important to try to sort out these variants. And we know that most of them will turn out not to be related to an increased risk for breast cancer. So what they did is something called a homology-directed repair. This is a laboratory methodology to look at these different variants and try to determine, based on looking at the DNA and then how that translates into RNA and proteins, to try to figure out whether or not these variants were important in producing an increased risk for breast cancer so that they could be clarified in the laboratory, not just by waiting for people to get breast cancer or not breast cancer and then make an association. And what they were able to find is that the vast majority of these variants were probably not going to be related to any kind of breast cancer increase. Can I use the pointer here? No, it doesn't work. So what they basically found by using this laboratory methodology, that they found a small minority of these variants would be related to an increased risk in breast cancer, but the ones that were related to an increased risk for breast cancer were very important and potent in increasing the risk. So this was an important step for us, allowing us to now take some of this information that we're getting on genetic testing and make it more understandable and clear to patients who and then can have a much more rapid translation from saying I have a variant to being able to say that variant is important or it's not important. So I thought this was an important discovery. Another category that I wanted to talk to you about was information that was presented about women who don't have breast cancer, but who have different conditions that are found in biopsies of the breast that we know are associated with an increased risk for breast cancer. So this is a talk that was given by Dr. Amy Degnan from the Mayo Clinic in Rochester, Minnesota. And the Mayo Clinic's had a really long-standing interest in women with these high-risk conditions. And they've accumulated registries and lots of data over the years that helps understand better what women's risk actually is. That'll lead us to a position where we can figure out what we can tell them to do about it. So the first thing that they talked about is when women have these atypical hyperplasia conditions identified on needle biopsies, for a very long time it has been considered standard that they then be recommended to have a surgical removal of the area to make sure that there's nothing more severe present at the time that the diagnosis of the atypical hyperplasia is made. And they reviewed a lot of literature on this subject that I think supports the idea that when women have a needle biopsy that shows atypical ductal hyperplasia, they really still need to have the area surgically excised because there's somewhere between a 15 and 25% chance that when the tissue is removed surgically, you will discover something more severe, and that could in fact be the beginning of breast cancer. So we're going to continue to do that. But there is some interest in figuring out, 15 to 25% is a significant number, but there's a lot of interest today in figuring out, is there a subset of people who have needle biopsies that show some of these conditions and don't necessarily need to have surgery? And Dr. Degnan talked about 3 different studies that are listed on the slide where they looked at very specific categories of women with very specific kind of abnormalities on mammography who might not need to have the area surgically excised if atypical hyperplasia is found on a needle biopsy, and that if you could in fact just subset out some of these different categories, you can see that the upgrade rate, which is at the bottom here of the slide on these 3 boxes, can really be very low, sort of 6% or below. And that suggests that there may be a category of women that have these atypical hyperplasias that do not actually need to have a surgical biopsy, very select group. Now, another kind of abnormality that can be seen on a needle biopsy is called flat epithelial atypia. It's another variant of that atypical hyperplasia category. And as you can see, looking at all of these selected studies, the percent when removed surgically that get upstaged to cancer is really very variable. Overall, it may be around 7% or so, but 36% of them, when you take them out, will certainly show still that there is a high-risk condition. And that's important because it means that these patients need to be followed more carefully because they are at increased risk. But you can also see that overall that's a lot less than the 15 to 25% rate for atypical ductal hyperplasia that we just looked at a minute ago. Another category of atypical hyperplasias would be atypical lobular hyperplasia, and then LCIS, sometimes called lobular neoplasia. These are also high-risk conditions that when you find them in the breast indicate that a woman is at increased risk for breast cancer. And when you look at the LCIS lesions, this data still supports the idea that they must be removed when they're found on needle biopsy because there is a significant rate of finding more important abnormalities, including cancers, within the tissue. The same cannot be said for the atypical lobular hyperplasia, which in some studies had a much lower rate of discovering cancer. But the real, I think, meat of this talk, more important to the audience than to the surgeon who's trying to figure out who actually needs surgery and who doesn't, the more important part of the talk is we really would like to be able to help women that have these conditions understand what their genuine risk of developing breast cancer is. And we'd like to make that information statistically valid, but also something that can translate into people understanding their risk on their own. So I think here's really the takeaway from this talk. When women have the abnormalities at the low end of the spectrum, like radial scars and some other fibrocystic changes, the absolute risk of developing breast cancer with those conditions is about 0.5% per year. With the atypical ductal or lobular hyperplasia, now you're jumping up to a risk of developing breast cancer that's about 1 to 2% per year. That's a real number. It's the same kind of risk that you can see if somebody has cancer in one breast. It's the same kind of risk that they have of developing cancer in the other breast. So that's a real significant number. And then with the LCIS diagnosis, sometimes called LCIS or lobular neoplasia, the risk of developing breast cancer is about 2% per year when that diagnosis is made. And this is important information that helps us counsel patients accurately and appropriately so they can figure out what they're willing to do for screening and prevention of breast cancer with this more precise understanding of their risk of developing the disease. So I thought this was a very good talk. Moving on to surgical treatment for breast cancer, topics in surgical treatment. This was a talk that I thought would be of great interest to the audience because this was a study looking at problems that people have with their arms after breast cancer surgery when they have developed breast cancer at a young age. So the morbidity in the arm after lymph node removal, lymphedema, and other symptoms is something that we're really concerned about and that we talk about a great deal. And this was a study that came out of the Dana-Farber Cancer Institute looking at the specific category of women who have this type of breast cancer surgery when they're young and what the outcomes are for their arms. So this so-called Young Women's Breast Cancer Study was done at many centers where they enrolled women who were less than 40 years old at the time of their diagnosis, and they enrolled women with the intent of following them carefully over time and surveying them, asking them questions about their arm to try to understand better what the actual risk would be for problems with the arm. And as you can see here, 1,300 women participated in this study. Now, the way that they conducted the study is that they asked the women questions about 4 months after the breast cancer diagnosis, then every 6 months for 3 years, and then once a year after that. They had a symptom checklist. They asked, have you experienced arm swelling or have you experienced a decreased range of motion in your arm on the side where you had surgery in the 4 weeks before you're filling out this questionnaire? And the responses are on a 5-point scale. Now, this is some information about the women that participated in the study. So they were young, median age was 37. The vast majority were Caucasian. Almost half of the women were fully employed. When they looked at BMI, at body mass index, and I think this is something important, if you look at women whose BMI was 25 or above, they had about 35% of their women who would be classified as overweight or obese. Now, I'm going to tell you, in our own institutional database, the percentage of women who are in the category of overweight or obese is closer to 50%. So I don't know if they eat a little better in Boston or in some of the other places, I don't know. But this data is interesting because we're going to see some of the conclusions in a minute. But our patient population seems to be trending towards a little bit of a higher BMI. They also measured something about socioeconomic status. They called it financially comfortable. I don't know what that means, but 51% of their patients were financially comfortable. That's going to come up in a minute as well. Now, when they looked at what kind of surgery the patients had, they characterized it by either breast-conserving surgery or mastectomy, 1 breast or 2 breasts. The percentage of these young women who had breast-conserving surgery was only 30%. I was a little surprised at that because, overall around the country, the percentage of women having breast-conserving surgery is more like 65%, but it's possible that because these women were very young, that skewed something about the choices that they made. But it's an interesting observation. 59% of their mastectomy patients had reconstructive surgery. Here, our percentages are higher than that, much higher than that. You can also see that the kind of lymph node surgery that people had was very carefully paid attention to, and about 55% of the patients had only removal of the sentinel nodes, the very selective lymph node removal after lymphatic mapping. They also collected how many patients had radiation treatment. The vast majority of breast-conserving surgery patients had radiation treatment, as you would expect, because it goes along with that treatment. But 50% of the mastectomy patients also had radiation, presumably because they had larger primary tumors and or positive lymph nodes. And they also collected information about things like chemotherapy and hormonal therapy in the patients. So here are some of the results. About 13% of all of the patients reported arm swelling 1 year after their surgery. This was 11% of people who had breast-conserving surgery and 14% of patients who had any sort of mastectomy, whether one side or both sides. About 33% of all patients reported some decrease in their range of motion at 1 year, and here it was about the same percentage of patients who underwent breast-conserving surgery and mastectomy surgery. Now, I was a little surprised when I saw that information, because we pay a lot of attention to our post-op patients, and we really, and anybody here who's had breast surgery here at NYU knows we do, and we drive everybody crazy, and we check their arm motion, and we send them for physical therapy, and we're all over that. So I thought that that number was a little bit high, but this is what the patient population reported. Now, they did see some significant differences in issues with the arm related to the type of surgery that women had. And certainly what they consistently demonstrated is that having more lymph nodes removed increased the risk of some of these issues with the arm. So when you look at arm swelling, whether you had breast-conserving surgery or you had mastectomy surgery, and with or without radiation, having more lymph nodes removed increased the rate of arm swelling, although once radiation was done after mastectomy, the numbers got a little bit closer to each other. On the other hand, the issue about range of motion really wasn't different dependent upon what kind of surgery that patients had. So that's an interesting observation. What they also found is that certain patient factors had a role to play in what happened with people's arms. So what they found is that having a higher body mass index, being overweight or obese, definitely increased the rate of issues with the arm, with arm swelling. That patients who seem to be in different comfortable financial status also decreased the risk of issues with the arm, which was interesting. And patients with larger tumors had a higher rate of having issues with arm swelling. Once again, not surprisingly, people who had axillary lymph node dissection with removal of more lymph nodes had more issues with arm swelling. When it came to range of motion, the data looks a little bit different. Here, the financial status didn't seem to have much to do with it. BMI, overweight or obese, had a marginal effect on whether or not people had issues with range of motion. But here, the interesting factor was that individuals who had radiation after mastectomy was the highest risk group for having issues with range of motion. And that is something that is not terribly surprising, particularly in the setting of women who have breast reconstruction and then also have radiation. Those women can be subject to different wound complications and issues with the arm that may lead to decreased range of motion. So what's the takeaway here? What are we learning from this information? So first of all, taking out more lymph nodes, having an axillary dissection, being overweight and obese, and being less comfortable financially were all associated with an increased risk for arm swelling after breast cancer surgery, as reported by patients. Patients who had mastectomies with radiation were twice as likely to have limitation in the range of motion of their arms as women who had breast-conserving surgery. So not terribly surprising, but certainly borne out by the data. So what are my caveats? I looked at this information, so what do I think about this? What am I learning from it? And what do I think might be influencing these results? So the first thing is to remember that all of these are self-reported symptoms. So someone may feel that their arm is swollen, but if you took a tape measure and you measured it, may not be the case. So that's one caveat. This is all about self-reported symptoms. The results that were reported in the study were all 1 year after surgery. It would be interesting to know how it evolved in later years. Did it get better? Did it get worse? Were there other interventions like physical therapy perhaps that might have had an influence on people's experience of these side effects. I think that was very interesting. And particularly the role of breast reconstruction wasn't accounted for in this data, and I believe that very likely it had some impact on the decreased range of motion seen in breast reconstruction patients. So for everybody out there who's had breast cancer surgery, we're very interested in symptom management. Nobody is kind of looking aside from that, even in the era of sentinel node dissections, but it will be helpful and important for us to figure out the high-risk groups so that we can employ more resources like physical therapy in that direction. Talking again about lymph node removal, this was a study that was done in Europe. The International Breast Cancer Study Group conducted a study looking at the lymph node removal in patients with micrometastases in the sentinel nodes. We've known for quite a while that if women have a very limited amount of disease in the sentinel nodes, there is no need to go back and remove the entire axillary group of lymph nodes. That was based on a study done in the US called the Z11 trial that was published a number of years ago. This trial was done in Europe, and unlike the Z11 trial, it included women not just having lumpectomy surgery, but women having mastectomy surgery, and tried to look at whether or not these patients needed to have the axillary lymph nodes removed if they had small amounts of disease in the sentinel nodes. So the patients who were included in this study had one or more lymph nodes involved with micrometastatic disease, so a little bit of disease, and then the patients were randomized to either having the rest of the lymph nodes removed or not, and just being closely observed. As we would expect, the groups were very well matched in terms of what kind of surgery the patients had, whether or not they had radiation treatment, and whether or not they had radiation treatment after mastectomy. So it's a good study. The two groups were evenly matched. If you look at these curves looking at disease-free survival, you can see that between the two groups, the group that had the axillary nodes removed and the group that didn't, you can't put a credit card between these two curves, right? The disease-free survival is identical, basically. And even if you look at breast cancer events over time in the lower graph, you can see that the graphs basically look the same. So taking out more lymph nodes in the group of women with a little bit of disease did not improve anyone's survival or decrease their chance of getting additional breast cancer events. Now, when they broke it down a little bit farther, there was one group where there seemed to be a little bit of a difference in terms of other events that happened. So in essence, patients who did not have axillary dissections, who had a little bit of disease in the sentinel nodes and did not have the remainder of the lymph nodes removed, had a slightly higher rate of having a recurrence of disease in the axilla, in the armpit. Now, these are very small numbers. So there's certainly a difference between 0.8% and 1.7%, but these are extremely small numbers. And the authors concluded from this study that just like the study done in the US, women who have small amounts of disease in the sentinel lymph nodes do not need to have a complete removal of the axillary nodes. So this leads on to the next talk that I'm going to give you a little bit of information of highlights on by Dr. Terry King from the Dana-Farber Cancer Center, talking about the topic of how do we individualize the management of the axillary lymph nodes in women with breast cancer. And she went through a lot of different scenarios in terms of what kinds of treatment people had and whether or not they had involvement of the lymph nodes that was clearly evident at the time of the diagnosis of their breast cancer. I want to draw your attention to the boxes in blue, which are women who come to the diagnosis of breast cancer with enlarged lymph nodes already under the arm that are involved with the cancer, and that is known at the time of the diagnosis. So if these patients go directly to surgery, the standard remains to do an axillary node dissection and remove the entire group. So no selective surgery. This has got to be an axillary dissection. For women in this category, however, who do chemotherapy and medical treatments before surgery, that's called neoadjuvant treatment, Then we may have some opportunity to individualize a little bit if they have a good response to the treatment, and if we can show that by MRIs and other tests that the lymph nodes have gone down, we may have an opportunity to be a little bit more selective about removing the lymph nodes. Now, we still have to be very careful after the upfront chemotherapy to make sure that we're mapping out the lymph nodes accurately, that we know which ones we have to remove, so that it's clear that unless you remove at least 3 lymph nodes, you don't have a lot of accuracy about the status of the axilla. There's not a lot of long-term data on the rate at which we get failures in the axilla. Will these patients go on years later to develop recurrence in the area? And we also know, as a caveat, that the MRIs that we do after chemotherapy and before surgery may not adequately or accurately determine the extent of the disease. But there is a lot of interest here on trying to help us figure out where we can limit lymph node removal for all the right reasons, including all that stuff we spoke about a few minutes ago about different side effects and complications. And perhaps if we're more careful about looking at which lymph nodes had cancer in them and tagging them in some way, and then making sure that when the patient has surgery, we are removing those lymph nodes for analysis, that may again help us be more selective in terms of removing lymph nodes. And I think that that was really the take-home message of this talk. Now, Dr. King also asked, is there a patient population today that does not require removal of lymph nodes at all as part of the treatment of their breast cancer? So it's a good question to ask and answer. And there is information that suggests that for older women who are over 70 years old, who have stage 1 breast cancers, that have a good profile, they're hormone sensitive and so on, that if we omit removing lymph nodes altogether, don't take out any lymph nodes at all, including sentinel nodes, that the rate at which they have disease recur in the node area is very, very low. And so therefore this may represent a population of patients who do not need to have lymph nodes removed at all, and that will spare them from any consequences in the future. So a lot of interesting directions about figuring out about more selectivity in removal of the lymph nodes. But once again, caveats. Some of the caveats about this information is that when you take out the lymph nodes underneath the arm, even though there is a difference whether you're selective or you remove the entire group, there is a difference in the side effects and the long-term complications. The risks are relatively low in all these categories. In addition, in some instances, when we take out fewer lymph nodes, it leads to an increased use of radiation in the area, and the radiation to the lymph node area is not without consequences as well, because there's no treatment that we give without any consequences. In addition, we feel like, especially for women with early stage disease, knowing about the lymph nodes gives the medical oncologists a lot of information about what kind of treatment the patient should have on a very precise level. So we don't want to get to a point where we're omitting this data point altogether. For some women, it helps us prevent them being overtreated. Now, I'm just going to show you one slide from this talk from Dr. Monica Morrow, who's the chief of the breast surgery service at Memorial Sloan Kettering, because one of the topics that she talked about in this talk had to do with patients who have had breast-conserving surgery. They've had lumpectomies, lymph node removal, and radiation, and then they get a recurrence in the breast. So standard approach has always been for these patients to have mastectomies, right? Because they failed that one way of treatment, and that's been the standard for a long, long time. But the question that comes up here and there is, why can't you just do another lumpectomy? What would be the results if you did that? We can't give radiation a second time to the entire breast. What happens if you just do a lumpectomy? And the answer is that in all of these studies that have been put together with women in just that situation, they had a lumpectomy, radiation, then had a recurrence in the breast, you can see that the rate of having another occurrence after that, a second recurrence, goes up and is significantly higher. And I think it supports the idea that the standard approach here should still be a mastectomy. Okay, the last talk that I'm going to talk about here has to do with patients with more extensive disease and looking at the potential role for surgery in women with advanced breast cancer. So about 6% of new breast cancers in the US, when they're diagnosed, are found to have some metastatic disease, the bone most commonly, but also potentially in other organs. Now, in many of these cases, the metastatic disease is extremely limited. And in women who go on clinical trials because they have metastatic disease at the time of diagnosis, about 50% of them will have very limited amounts of metastatic disease. Now, we are in the process of having very clearly information that shows that women with metastatic breast cancer are living longer and longer. So we know that. That's a good thing, and we've noticed that for a long time. And to the point where there's actually interest in determining whether or not these women profit by having some of those metastatic sites removed. If you have a met to the liver, and it's just one met, would you give the patient a better survival if you take it out? If you remove lung mets, do you help the patient at all? So there's a lot of interest in this right now based on the longer survival. The median survival, the 3-year survival for patients with stage 4 disease in 2015 was about 40%, which is better than it was in the past. Now, in these patients who have metastatic disease, leaving the primary tumor intact in the breast gives you something very easy to monitor for response to disease. But leaving the primary tumor present within the breast can produce some symptoms and also can impact on the patient's quality of life. There are 2 randomized trials that have been done looking at the impact of surgery on women with metastatic disease. And both of them are trials that were done outside of the US. And they have some very significant methodological problems with both of these trials. In the trial that was done in Turkey, there was an improvement in 5-year survival in women with metastatic breast cancer who had surgery on the breast to remove the primary. And it looks like women who were younger and who had hormone-sensitive cancers actually seemed to do better. And that's not a surprise because that tends to be a patient population, at least the hormone-sensitive ones, that would ultimately do better. In the US, a trial was opened in February of 2011 to try to enroll women who had metastatic disease that was well controlled and randomize them to having surgical intervention or not to allow us to then look at the outcomes. The trial was very challenged. It was difficult to enroll women and accrue women into the trial. They've now reduced the estimates of patients required to come to some conclusions, and we hope, the trial's now closed, we hope for some information to come out of this in the near future. But the bottom line is that in patients with good survival, good response to treatment, good projected survival, there is probably some role for surgical treatment, but that it really shouldn't be offered to women unless their metastatic disease is very well controlled and they seem to have a reasonable survival afterwards. So to summarize some of the topics that I've spoken about, Dr. Couch's group reported on a new method in the laboratory that's going to help us reclassify some of these variants that we're reporting now on genetic testing that have been unclear about their importance. We know that both atypical ductal and lobular hyperplasia are associated with an increased risk for breast cancer of about 1% to 2% per year, and that LCIS has a higher rate of developing breast cancer than either two. Women who have breast cancer surgery that involves removing the entire axillary lymph node group, women who are overweight or obese and have lower socioeconomic status, are more at risk for postoperative arm swelling, and patients who have mastectomies with radiation afterwards are at more risk of decreased range of motion for the arm after surgery. For people who have minimal disease in the lymph nodes, we can still do selective lymph node removal. Removing the whole group doesn't seem to improve their survival, and women who have had a lumpectomy and radiation and then recur within the breast should probably still be counseled that mastectomy is the standard approach. The role for surgery in the breast and in the axilla in patients with metastatic disease is unclear, but as survivals are increasing in this group, it is a group of patients that we need to take a look at more closely and hopefully come up with some better answers as to the potential benefit or lack thereof for surgery in this group. Okay, so thank you, and I think we're going to move on with more remarks and we'll take questions at the end.